Cardiovascular causes of sudden infant death. Alpay Saliker MD. Hacettepe University. Pediatric Cardiology Department. Ankara, Turkey. Sudden infant death syndrome. Unexplained, unexpected death within the first year of life. There is no obvious cause of death on postmortem examination. Postulated hypotheses: abnormal brainstem respiratory control of arousal, dysautonomia, malignant cardiac arrhythmias. Risk factors: prematurity, siblings of SIDS victim, maternal drug use, prone sleeping position, multiple gestations. Laboratory tests: EEG, pulse oximetry, ECG, Holter, sleep studies, apnea monitorization. Causes of cardiovascular sudden death. Children with known heart disease, aortic stenosis, congenital heart block, cardiomyopathy and myocarditis. Children with unknown heart disease, hypertrophic cardiomyopathy, long QT syndrome, Wolff-Parkinson-White syndrome, primary ventricular tachycardia and ventricular fibrillation. Sudden cardiac death. VT and VF. VT. VF. Polymorphic VT. Polymorphic ventricular tachycardia. Congenital long QT syndrome. Acquired long QT syndrome. Cathecholaminergic polymorphic VT. Idiopathic VT and VF. Brugada syndrome. Normal ECG, Bellison, long QT syndrome, prevalence and history. On the basis of molecular genetics, the prevalence of LQTS estimated to be 1 per 3,000 to 4,000 births. Description: 1957, Jervell Lang Nielsen, and 1963/64, Romano Ward. Registry, 1979, Moss and Schwartz. Genetic analysis, 1991, Keating. Clinical findings: syncope, family history, ECG findings, genetics. QT interval prolongation. Abnormal T morphology. Prolonged QT dispersion. D-wave alternans. Low heart rate. Avenue blocks. Genetics. Echo findings. Syncope attacks. Syncope occurs due to torsade de pointes or ventricular fibrillation. Syncope develops during excitement or crying, especially during fear or excitement. Physical activity, swimming. Syncope may occur during rest periods in LQTS3 type. Torsade de pointes. Polymorphic, twisted axis VT. Causes of syncope. QT interval. Corrected QT interval, QTC, can be measured by Bazet formula. It should be measured from DI. It is abnormal if prolonged more than 440 ms. It is more pronounced in sick girls. There are some cases with normal QT interval, abnormal genotype, normal phenotype. Measurement of QTC interval. Bazet formula. QTC equals QT interval. RR. QTC equals 0.52 seconds. 1. 21 seconds. 0.48 seconds or 480 milsec. Age and sex and QTC, second, 1 to 15-year men, women normal less than 0.44, less than 0.43. Less than 0.45. Borderline. 0.44 to 0.46. 0.43 to 0.45. 0.45 to 0.47. Prolonged. Greater than 0.47. Greater than 0.46. Greater than 0.48. T morphology. There are changes in T-wave morphology beside long QT interval. T-wave may be biphasic or humped. These findings are generally seen in V2-V5 leads, and prominent in V3 and V4. This finding may be exaggerated after exercise test. Humps are generated by early after depolarization, EAD, and it is more common in symptomatic cases. T-wave changes. LQT3, LQT2, LQT1. Heart rate abnormalities. There is bradycardia. This feature is more apparent in children. Exercise test may also show inappropriately low heart rate increase. There may be greater than 1.2 seconds pause without marked sinus arrhythmia, and this may provoke TDP. After pauses, some may see humps at T-wave. Molecular genetics, sensory neural deafness type gen. Inheritance. Gen and ion channel. Triggered causes. T-wave. LQT1. ODE. 11p5.5. KVLQT1, X. Stress, swimming. YT. LQT2. 7q3536. HERG, ICR. Stress, fear. T-wave with hump and low volume. LQT3. 3p2124. SCN5A, NA channel. Sleeping. Normal, late T. LQT4. 4q2527. Sinusoidal TU, AF. LQT5. 21q22. KCNE1, MINC, X. LQT6. KCNE2, MERP1, ICR. JLN1-2. Or KCNE1, ICR. Sensory neural deafness, molecular abnormalities in LQTS. Genetics I. Molecular analysis should be done in patients and their families. Molecular analysis is very helpful in asymptomatic carriers. Genetic analysis can reveal molecular diagnosis in 30 to 50% of patients, since many of the genes responsible for LQTS have not been known nowadays. Molecular diagnosis may take several months. Genetics 2. Gene-specific treatment can be used after genetic analysis. In LQTS3, mexiltine, NA channel blocking agent, may lessen QT interval and attacks. Incomplete penetration is very common. Ventricular arrhythmia can be seen in some conditions in these patients. Some drugs may cause prolonged QT interval in these cases. QT interval would be normal if this drug will be stopped. Incomplete penetration. Diagnostic criteria: ECG findings, points history, family history. QDC. Greater than 480 ms3. 460 to 470 ms2. 450 ms1. Torsade de points 2. T-wave alternans 1. Humps at 3 ECG leads 1. Low heart rate 0.5. History. Stress-induced syncope 2. Syncope without stress 1. Congenital deafness 0.5. Family history. LQTS family cases 1. Less than 30-year unexpected sudden death 0.5. Less than 1 point, low probability, 2 to 3 point, moderate probability LQTS. Greater than 4 point, high probability LQTS, treatment permanent pacemaker implantation. Blockage. Permanent pacemaker implantation. Left cardiac sympathetic denervation. ICD, implantable cardiac defibrillator. Gene-specific treatment. Avoid of drugs that prolongs QT interval. Long QTV second degree type 2 avenue block. Drugs should be avoided. Drugs causes QT interval prolongation. Phenothiazines, Haldol, chlorpromazine versus tricyclic antidepressants, imipramine, lithium. Macrolide antibiotics, erythromycin, azithromycin, cetoconazole. Non-sedative antihistamines, terfenadine, estomazole. Class IAA drugs, quinidine, procainamide, disopyramide. Class 3AA drugs, sotalol, amiodarone. Gastric motility agents, chisapride. Stimulants. Metylxanthins, methylphenidate. Drug abuse and addicts. Nicotine, cocaine, amphetamine, marijuana, LSD, phencyclidine, pentamidine. Procainamide. Hypokalemia. SIDS and long QT syndrome. Schwartz et al. Demonstrated a correlation between QT prolongation and SIDS. In the first 48 hours there is a transient QT prolongation, fewer than 2 to 3 per 1,000, secondary to fetal maternal electrolyte fluxes and transient alterations in autonomic control. ECG screening should be done after a few days of life. The efficacy of therapeutic interventions in infants with prolonged QT interval is impossible to predict, since many of these prolongations are due to transient autonomic instability. Schwartz P.J. et al. Prolonged QT and SIDS. Nguyen, J. Med. 330, 709, 1998. Schwartz P.J. et al. Prolonged QT and SIDS. Long QT and SIDS. 34.462 healthy newborn enrolled and 33.064 could be followed for 1 year. 12 lead ECGs were obtained at the 3rd or 4th day of life, and RR, QT and QTC intervals were measured from lead 2. 1,408 children were lost to follow-up when their families moved. Schwartz P.J. et al. Prolonged QT and SIDS. There was no difference between SIDS and others regarding sex. During 1 year of follow-up there were 34 deaths, 24 due to SIDS and 10 due to other causes. The incidence of SIDS was 0.7 per 1,000. Most deaths due to SIDS occurred in the 2nd and 3rd month of life. There was no difference between SIDS and others regarding sex. No victim of SIDS had a family history of LQTS. Schwartz P.J. et al. Prolonged QT and SIDS. ECG findings. Heart rate were not different between groups. QTC. SIDS, 43,545 msec. Non-SIDS deaths, 39,324 msec, p less than 0.05. Survivors, 40,020 msec, p less than 0.05. 12 of 24 infants who died of SIDS, 50%, had a QTC greater than 440 msec. Schwartz P.J. et al. Prolonged QT and SIDS. Schwartz P.J. et al. Prolonged QT and SIDS. Schwartz et al. Ng. J. Med. 1999. They showed SCN5A mutation in this recited sudden death case. Prevention of SIDS. Assessment of family history. ECG recordings at 2 to 3 weeks after birth. If QTC 470 msec after second ECG, blockers may be used. Schwartz P.J. Long QT syndrome and SIDS. Major drawbacks. International studies have failed to demonstrate any excess of SIDS in families with known LQTS. The incidence of SIDS is rare in some countries. The incidence of sudden death decreased by changing of sleep position, cessation of parental smoking. There is no proven relationship between the prolonged QT and molecular diagnosis. Problems of screening methods. There is no consensus on diagnosis and treatment. Wolff-Parkinson-White syndrome. The incidence in children is 0.1%. If there is a rapidly conducting accessory pathway, atrial fibrillation may cause DVF. Some proarrhythmic, new arrhythmia caused by antiarrhythmic drugs. Antiarrhythmic drugs may also cause this complication. SVE. WPW syndrome and VF. Atrial fibrillation is more common in patients with this syndrome. If accessory pathway refractory period is less than 220 ms, there is a risk of ventricular fibrillation during atrial fibrillation. Some drugs that prolongs avenue conduction may provoke VF during AF due to rapid conduction via AP. AF. Manifest WPW. VF. Congenital heart block I. These babies have been diagnosed due to low heart rates. But most of them do not need pacemaker implantation. Close follow-up is mandatory to avoid the sudden cardiac death. Pacemaker indications, Class I. No CHD, awake heart rate less than 65 bpm. CHD, awake heart rate less than 55 bpm. Heart failure. Prolonged QT interval. Congenital heart block II. Mothers of babies with congenital avenue block should be evaluated for anti-nuclear antibodies. QT interval measurement is very important, since long QT syndrome may be the cause of avenue block. Prolonged repolarization results with avenue block, complete heart block. QRS. 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 P waves. Permanent pacemaker. Dilated cardiomyopathy and myocarditis. The etiology of DCM is idiopathic. Only 2 to 15% of the children with DCM has biopsy-proven myocarditis. There are familial DCM cases. Histologic features classically include myocyte hypertrophy, degeneration and varying degrees of interstitial fibrosis. There is ventricular dilation and decreased left ventricular systolic function. Dilated cardiomyopathy. Dilated cardiomyopathy and myocarditis. Fibrosis of ventricular myocardium may occur, resulting in an irritable focus that causes ventricular arrhythmias. In Holter monitoring 46% of patients had arrhythmias. Ventricular arrhythmias are more common than atrial arrhythmias. If there is a serious ventricular arrhythmia, amiodarone should be the drug of choice to prevent sudden death. Myocarditis. Acute or myocarditis have been reported as pathologic findings in up to 42% of patients with SCD. Some patients may have subtle findings such as tachycardia and low-grade ventricular ectopy. Occasionally avenue block may develop during myocarditis. Hypertrophic cardiomyopathy. It is the most common hereditary cardiac disease. Left ventricular outflow tract obstruction and diastolic dysfunction are the main pathophysiologic abnormalities. The histologic features consistent with HCM include myocyte hypertrophy with great variation in size and shape, cardiac muscle cell disarray, fibrosis and abnormalities of small intramural coronary arteries. Hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. Muscle cell disarray may be a reason for ventricular arrhythmias. Any kind of supraventricular and ventricular arrhythmias may occur in patients with HCM. HCM is the most common cause of sudden cardiac death in young adults. The prognosis of infants who present before 1 year of age continues to be dismal. Amiodarone has been suggested as an effective medication for the treatment of rhythm problems. Sometimes ICD implantation is required to prevent sudden death due to VF. Aortic stenosis. The incidence of sudden death is 5.4% in patients with AS. The development of myocardial ischemia is thought to be the initiating factor for terminal ventricular arrhythmias in patients with severe AS. Syncope, chest pain, dyspnea, left ventricular strain on ECG, severe LVOT obstruction were identified as risk factors for SCD, coronary artery anomalies. These anomalies may be diagnosed during postmortem examination. Types of anomalies. Anomalous origin of left coronary artery from pulmonary artery, ALCAPA. Left main coronary artery from the right sinus valsalva. Acute angle takeoff of a coronary artery. Intramural coronary artery. Single right coronary artery. ALCAPA is the most common type that presents symptoms during infancy.